Great. Thanks, Dr. Lori, and thanks all for being here today. I'm excited to share this talk with you in this setting, and this is a little bit about what I've been working on for the last 10 years. So what are we going to talk about today? Okay, so why think global? Why does it matter? What else is going on in the world when what we have here is there's so many problems and so many issues and so many unsolved mysteries? Why Africa? Specifically, the country that I partner with is Zambia, which is a country in sub-Saharan Africa. So this is when I first traveled there for the first time, again, about 10 years ago. This is where Zambia is located on the continent of Africa. And Spina Bifida, Chiari malformation runs with that. Syringomyelia runs with that. Why does that matter? Research, clinical, advocacy, three main arms with it. And then kind of talk a little bit about a summary after that. So why think global? So the U.S. is a world leader in spina bifida care. And spina bifida, Chiari, Syringomyelia, the scoliosis that runs with that, all of those things go together. So what makes us a world leader? One is this meeting right here and the group of individuals that are committed to helping to improve care for others around our country and the world. There's other main organizations, too, that focus on this. One is the Spina Bifida Association, and there's subgroups throughout the United States as well. So the point that I'm making is we're strong, okay? Promote access to quality healthcare worldwide. So we have something to share with the rest of the world, but also the rest of the world has something to share with us. So this disease, in general, is one that is relatively rare, for example, compared to heart attacks. That being said, we know that it is a common disease that causes a significant problem with disability, with interference with quality of life, and so it deserves to be studied intensively. So there are international organizations. This one is run out of Belgium, and the International Federation for Spina Bifida Hydrocephalus and the issues that run with that. And then ultimately, it's to address preventable disability and death. So how can we learn from one another? And what we found is that if you catch these conditions early, it can prevent many issues down the line. So that international organization that I was talking about, these are some of its locations all around the world, okay? There are many people that are interested from around the world to try to study this condition, Chiari, Syringomyelia, Spina Bifida, together, and how can we pool our resources to help study this relatively rare condition to improve care for those who have it. So mapping the disease burden and the mortality that runs with it. So we're going to look at maps today. On this page. So red means there's a lot, and green means it's not a lot and relative to each other. So what we find is, again, this is in reference to spina bifida and the conditions that run with it. So what we find is it's much more common in South America and Africa compared, for example, to the United States. That doesn't mean it's rare in the United States, but it does mean that there are other countries that have a higher number of patients that have this condition. When you look more closely at each of these countries, you see, for example, in Africa, it's not whole countries that are colored in, it's dots. And that's because data is relatively lacking from the African continent in general. Europe has more filled in, and you can see that Europe has a similar incidence or frequency of this disease as we do in the United States. But ultimately, what we also see is not only is the disease more common in Africa or South America, for example, we also see that more people are dying from this disease. It's causing more significant disability and impact on people's lives. So again, this is aggregate data. There's many individuals, so you have to see the trees within the forest. But this is the global view of what we're looking at. So differences in quality of care. So again, why does global matter? What are the different things that could be contributing to this? So why is there a difference in disease burden? Why is there a difference in number of people dying from this disease? One can be timely access to care. As I mentioned, trying to have this diagnosis when you're young can make a significant impact and improvement in your life as you go through it. So this is a picture in Africa. I was driving. Full disclosure, don't do this when you're driving. But I was sitting in traffic. So you can see that is this wearing a seatbelt? Right? No. So many don't own a car in Zambia, which is what I can speak to. So what we see when we compare low-income countries to high-income countries, which the United States is a high-income country, right? We have a high GDP. Low-income countries, again, these are classified by the World Bank, who stratifies every country in the world. tend to have a farther distance to get to care. This is a problem we have in the United States too. Right here in Iowa, we're the major center for the entire state. There are certain states that have a lot more centers and patients that can live within 15 minutes of needing care, but that's not true everywhere. And Zambia is no exception to that. So access to safe neurosurgery. So available specialists. So again, another map. Red, not a lot of neurosurgeons. Green, more neurosurgeons. White, we don't know. They don't have any data. So what we see is that as certain countries don't have as many doctors for the number of patients that have the condition. So not only does Africa have more patients, they don't have as many doctors to take care of those patients. No supplies. So this was a recent study. I guess it's not so recent anymore, in the last 5 to 10 years or so. And they're looking at, what do the hospitals have? This was done in Rwanda. But 22% didn't have running water, 24% without oxygen, electricity, a blood bank. All of these things are fundamental parts of what we need to provide safe healthcare. And ultimately what it comes down to is it's very costly for patients. And again, this is a problem we have here, but what can we learn together? How can we leverage our partners to be able to improve the care here in the United States? So why Africa? How did I end up there? Zambia. I'd never been there before 10 years ago. Okay. So Africa to the world. When you hear the word Africa, right, it's a continent. We often refer to it similar to as if it were a country, but it's actually an amalgamation, depending on the political unrest at the time, around 50 to 60 countries. So you think of village huts with thatched roofs, which this is a picture from Zambia that is there. Okay. You may think of the Lion King and Mufasa. Okay. You may think of zebras and wildlife that you commonly see at the zoo, which again, this picture was taken there too in our backyard. Okay. You may think of Mount Kilimanjaro and the beautiful scenery that is there, or safaris, or the apartheid, what happened, 30 years ago in South Africa. But this is Africa on the ground. It's beautiful. The people there are incredibly hardworking and love to work together, and they're industrious. So, I counted this, I think this was almost 50 dozen eggs, 50 flats of eggs strapped on somebody's bicycle, right, to try to deliver it from the farm. So they're incredibly hardworking individuals, not unlike ourselves. So why Zambia? So on this map, right, of proportion of those without access to safe surgery, Zambia is as dark as it gets, okay? So this is clearly a country that is one that would benefit from additional resources or research, or how can we collaborate and learn, again, from one another? So eventually you may be asking, what could this country where you're saying there's no running water, there's no electricity, which is not true, it has it, right, but it's percentages. What could they possibly offer us to help improve our care here in the United States? So Zambia, when I talk about it in this talk, this is the country zoomed in, right? North is the Congo, Zimbabwe to the south, Malawi to the right, Angola to the west. Lusaka is the capital. So Spina Bifida has a high burden of disease. Again, these maps I showed earlier, I bring them up one more time to say this is a common condition. Chiari, Syringomyelia, Spina Bifida, the conditions that run with it, tethered cord, okay? We know that it happens there a lot. We know that the disease is severe. What can this offer us to insights here in the United States? So you talk about making a pretty big investment, proposing a partnership with a country that's halfway around the world. There's oceans that separate us, okay? But this is something that a colleague of mine shared with me several years ago, and I've since shared it with many others. You take it one panel at a time. So when you're taking care of others, you've got a guy trapped in the hole, right? I'm going to give you some medicines. I'm going to throw him in, and then I'll come back again tomorrow and throw him in again. Is the guy ever going to get out of the hole? No, okay? So what about this? Oh, the guy's stuck in the hole. Let me go get a rope. I'm going to pull you out this time. What happens if he were to fall in again? What's going to get him out the next time if you're not there? Okay. What about this last portion here? Let's figure out a way to get out together so that if you ever get stuck in this hole again, you can get out on your own and you don't need me. So Spina Bifida in Zambia, again, a low and middle income country. So this is a different spectrum of disease. So this is one, for example, one of the children that we've taken care of. This is what Spina Bifida looks like with specifics to myelomeningocele, the subtype of Spina Bifida, right? This is typically born without skin covered over it. But this is one that the child came in several months later and the skin had already grown over the CSF pocket that was leaking out of the back. The child survived. So it's something that offers, this is not something we see here, right? Children may be born with this condition. It's recognized immediately, and we take care of it within a few days of life, if safe to do so. Hydrocephalus or fluid disorders, that their heads get quite large as infants because, again, they often present late. They don't have reliable access to it. So we can study natural history of disease, which can, again, if left untreated, what does this do? Again, which leads to why is it important to catch it early and to treat it? Costs are less there. So these are examples of shunt catheters that we use. One here, this is what we use in Zambia, $75 US, okay? Equivalent system here, this may be outdated, it may be more now, but similar shunt system that we use here in the United States, $3,400, right? That's just for the tubing, let alone the time and the postoperative care and the things that come with it. So there's three principles that I think about when I think about international partnerships and how it pertains to improving and advancing healthcare. One is learning a different culture and clinical system. So when you think about learning a different culture and clinical system, this is a paper that was published in The Lancet, which is one of our main medical journals that we look to as kind of a gold standard of care and tends to have very high quality papers that are written in it. So when you think about kids with disabilities, so I'm going to read what is highlighted in red here. It is small, and I apologize. So when you think about a child with a disability, they say it is a punishment from God, witchcraft, the fault of the mother, reincarnation. These are all frequently stated causes for disability of children in Africa. Such false beliefs are deeply rooted in tradition and culture. In truth, most children with disabilities in Africa have been disabled by the sad predicaments that continue to haunt the continent: war, poverty, and inadequate access to healthcare. So a knowledge of what your patients are thinking, a knowledge of where they're coming from, can help impact the care that you provide. Second principle, you can't keep giving money. You'll eventually run out of money. This was told to me by one of the Zambian doctors when I was first there, again, about 10 years ago. And I've carried it with me every day. So if you continue to send money, I'm just going to donate, right? I'm going to send money. I have it at my fingertips. Click the button. Is it going to impact change? You definitely need money to make change, but money alone won't change the world. So, for example, when we talk about donations or we talk about investment in partnerships, we think about breadth and we think about commitment. The things that will have the highest amount of impact on a patient's life or a group's life will be those that are wide in breadth, they reach a large number of people, and they take a lot of time. They're high in commitment. And together, that's a committed partnership. So you can donate, and that will help. You can teach, and that will help too. You can travel there intermittently, and if you happen to be there again when the man is in the hole and you can take him out, that helps too. All of these things are important. But the thing that's really going to make the lasting change and sustain over time is the partnership. So this is something that, political unrest, this is something that happened when I was living there. So there was an election and there were some things that were going on in South Africa. And so there was a protest, right? And so that's the key piece, that we tend to have pretty significant ebbs and flows on the African continent. It's a less stable democracy. And so that's something that you always have to factor in with the partnership as well. The third principle is that surgery can be simple. It can be the easiest part of the whole thing when you're negotiating through or navigating a partnership and trying to build a community. So this is surgeries that I do there. This was, I believe, a shunt and partnerships that we're working on. This is all we need. It's like 20 instruments, right? If you looked inside an OR here in the United States, an operating room, you would not see a tray like that. Okay, you'd see significantly more. You'd see hundreds of instruments for any given operation. So does that make our surgery any better? In some ways, yes, it depends on the surgery. But are there things, we also know that costs in healthcare are a problem here in the United States. So are we doing more than we need to? Do we have more instruments than we need for a given case, for an example? So there's opportunities to learn from one another. So I take a three-pronged approach when I think about collaborative care and collaborative partnerships to try to improve patient care. Clinical, we've talked about a little bit. I'm going to talk a little bit more about research, and then I'm going to finish with advocacy. So this is the hospital that I work at when I travel there. So research. when you're trying to start a research partnership, and I believe the Park Reeves Consortium has been one of the major research drivers within Chiari care here in the United States. The research that has come from that has driven dramatic changes in the care of patients with Chiari and Syringomyelia. So, when we think about how can we add to that? So we're assembling our team. So in Zambia, this is the team that I work with there. They're invested parties. There's a team of nurses, doctors, and trainees to carry the path forward. You have to get stakeholder buy-in. So not only just going there, right, and having a few people that you work with, but the whole hospital, right? Physical therapists, nurse practitioners, doctors, administrators, they have to come around a common goal and make that their mission to work together to move forward. And determine your resources. So, Care House of Hope is a nonprofit that I helped start and work with there that works with families who didn't have housing. Not so different if you may be familiar with the Ronald McDonald House here in the United States that helps families who are traveling from long distances have a place to stay, so all of their costs are not eaten by hotel bills. And Angela is the woman who runs that full time. And, another resource you have to think about whenever you think about research is where is your information going to come from? So you need a large patient population to drive research, and research drives change and care improvement. So this is the medical records at the hospital I work with. It's definitely not electronic. And so that's something that takes a lot of hours to go through those paper charts. As you can imagine, the organization may not be as ideal as an electronic record. So the Care House of Hope was developed for mothers of children with spina bifida, mothers of children with hydrocephalus, Chiari malformation, Syringomyelia. Purpose was to bridge the financial gap, provide a safe shelter. We found many of these mothers were sleeping on the street because shelter was not provided and they didn't have enough money. And so we created a place for them to have money and to have a place to stay and to have food while their child was in the hospital for extended periods of time. And it also empowers them. So it teaches patient care needs. Mothers, nurses work together to help understand the care of complex children. So you're working on assembling your team. You've got the people involved with it. You've got an idea of what you're going to do. Now you need to figure out what exactly is the problem that you want to start. There's a lot of different problems to address. As we kind of heard in the last talk, there's a number of different ways to approach the same problem. What's the best way? And oftentimes it needs patient-centered care, but if you can try to identify themes, that's how you'll drive change. So spina bifida is expected to be 20 times more common in Zambia than it is here in the United States. Our group published on this a few years ago. We know that there's delayed access to care. So these kids typically don't come to the NICU there until they're 9 days old. They were born somewhere else. And so we know that it takes a while to travel to the main hospital that provides pediatric neurosurgical services. And then they don't have surgery until they're about 3 weeks old. So it's a different population in that way. But what we noticed is that, there seems to be a higher infection rate. There's a high complication rate. But our rates for this surgery in the United States are not low either. It runs 10 to 20%. So we're not that different in Africa than Zambia, I should say, in that way. We're slightly better, but 10%, 20% complication rate, that's pretty high. We could do better. So what does this mean? We know that prenatal vitamins can help prevent some forms of spina bifida. We know that spina bifida runs with Chiari, it runs with Syringomyelia. So how can we use this information to help us? Is it a similar enough patient population to help inform care here in the United States? So the group of neurosurgeons here, governing body, is one of them, is the Congress of Neurological Surgeons. And they strove in the last few years to try to assemble guidelines for certain neurosurgical conditions. One of them is spina bifida in kids. And when they put this together, they said, you really, based on the data that we have, you need to do this surgery within 48 hours. And so there's been 48 to 72. And so there's been a big push here to say, you need to do this surgery within this period of time when this child is born. But what we're also seeing, right, is that we're getting really good at having babies survive that are born really, really early and really, really tiny. And what if that baby had spina bifida? Should that baby be rushed to surgery or should that baby wait? So, there's different ways to think about this problem. What if this scenario? What if this scenario? Everything is not black and white. So this time cutoff doesn't have a lot of research supporting it. There's a couple of studies about 30 years ago that had some suggestions of change. And so we decided we were going to study this in a prospective fashion. So over the last year, we've been enrolling infants born with spina bifida in Zambia at one hospital. We have 110 babies enrolled so far. And this is what we're studying. Does the timing of surgery affect your brain and how it develops? Does it impact how your bladder functions? Does it impact if survival, infection, complications that are associated with that? We're just getting started. So this study, again, started a year ago overall, and research takes time and investment. But where I'd like to see this project taken then becomes Chiari, becomes Syringomyelia. Are these things that are making a significant difference in these children or not? Or is it exactly the same? Because as we start to establish similarities between this population, 110 children at one institution with spina bifida in 1 year does not happen in the United States. And we know that with the way our healthcare system works here, we partner together as hospitals and we pool patients. You get 5 patients from this hospital, you get 10 from that one. It's really hard to get aggregate data from one person controlling, trying to collect the same information from every patient every time. So this is what's unique. And this is what offers the answer, is that there is a large patient population in one place that you can control very closely about different interventions and try to study how that makes a difference. And how does that translate here to the United States? So this is a multidisciplinary effort. We have people from all different specialties involved to make this study happen. So spina bifida, right, is a disease, and incidence and severity is variable. There's a high patient burden, and that's what powers research. And research is what drives advances in care. So is there a potential for patient-centered care here, like I was talking about? So, for example, premature babies. Or severity, right? We know that the severity is more significant in Zambia, but that doesn't mean there isn't severe disease here in the United States. And you may have been told, or somebody at some point that in health with any kind of condition said, I've just never seen anything like this. Is there actually other patients out there that are exactly like you? So this is something where I think the future lay. I think it offers an opportunity for us to be able to study what is a relatively rare condition in an aggregate form and to be able to take that information and bring it back here to the United States. Again, the future we're hoping for is to be able to look a little bit more closely about Chiari, Syringomyelia. And again, if you have a large enough patient population working together, I wonder if it's the disease that you could prevent entirely one day. So when I think about, delays for surgical care in infants and how to advance progress, I think about, how can we improve the ability to know that you have this diagnosis, to know that, or know that something is wrong and that you need help. Once you know you need help, how do you get help? And how do you get the right help? And then how do you get the help that you need? And once you find the person, how do you know that that person knows what to do? How do you find the right person? So with that, research then feeds into advocacy. So some of the things that I've noticed with this, again, as we see, this is a high disease that happens frequently in different parts of the world, and it has regional variation. So be the change you wish to see, right? And so these are countries, we know that spina bifida, and the way to prevent some forms of spina bifida is with folic acid, which is, a vitamin that women are advised to take if they're thinking about getting pregnant or are pregnant. And these are countries that fortify their food with folic acid. And you can see we do wheat, corn, rice, we cover our bases here in the United States because that's where that research came from. And because of that reduced the incidence of spina bifida by 30% in the United States when that research came out in the 1990s. That has prevented syringomyelia and Chiari malformation in that population of patients, and they will never know. But that's because of the work that everyone worked together to find out what it was, that there was such a high burden of patients that had this particular condition, and that drove efforts to make that change in research. And now what you need to do is, okay, even though we know this, there's all these countries that don't do it. So how do you advocate for that change? And so that was really where neurosurgery has been engaged with the World Health Organization in 2023, where there was a new World Health Assembly, that's the annual meeting of the WHO, that said now there's a new amendment. So it took almost 30 years from that finding that folic acid, prevents this disease before advocacy caught up with it, before politics caught up with it, before bureaucracy caught up with it. So all of these things, this was a huge breakthrough. So now by doing this, there's funding available to these countries that can't afford it, or countries that need a little help and want a little help for it to be able to implement these changes and change the lives of these children who then grow on into adults forever. So in summary, this is my last slide, lessons learned throughout all of this. So what I've learned is that you need to be flexible. So a country or a different surgical group, even here in the United States, may do things differently than you ever did before. When I came to Iowa, I learned different things, right, from where I grew from. My training is at Vanderbilt and at Johns Hopkins. So even within the United States, we do things differently. And when you go see how a different healthcare system does things outside our own, you even learn more. And that's how you get better. And that's how you improve. We can always improve throughout our life. Get creative. So you may not have everything, right? You may not have exactly the right answer. But what you do have is the tools to potentially be able to get there. So how can you put things together that may not be exactly what you thought they were going to be, but still make it work? And again, sometimes that's what discovery comes from, making something new. Remember the costs. So costs of healthcare are astronomical. This is a big passion of mine. Okay, how do we improve the costs of healthcare such that our patients and our families aren't eaten alive by the costs that come with this? Roadblocks will occur. I can't tell you how many times I've been told no, or this is ridiculous, or I don't see a point. But stay true to your mission, stay true to your cause, and you will get to where you want to go. Lastly, a different way is not always a bad way. Again, there's a lot of different ways to do things, and sometimes trying things a little bit differently can mean that you're going to get to where you want to go, and it may in fact be better than what the original way that you thought you were going to get there. So in summary, this is a roadblock that I recently encountered on a trip to Zimbabwe. I was in a car at the time, and I'll let you think about how I got around that one. So I'll take any questions.